I know I've seen you use multiple different modalities, but what are the modalities that you're using in your practice for
Yeah,
focal
good
therapy?
question. So again, I think this can vary depending on, the system and, where you guys are located or where anyone's located in the country. But, I think at Hackensack University Medical Center, our primary modality is high intensity focused ultrasound, and that's a transrectal probe that we do. We also use cryotherapy. And so I think I get a lot of questions, from people who are trying to build out their focal programs, like, what exactly do you need? Like, what is the infrastructure you really need to be able to build a focal therapy program? And I'd say, you probably need at least two therapies. And the reason is because every therapy, every modality has their pros and their cons. For high intensity focused ultrasounds, the transrectal probe, you're putting this probe into the rectum and you're trying to irradiate prostates, or sorry, radiate, try to ablate the prostates. You can tell that, large prostates or disease that's kind of anterior to the urethra or in the top part of the prostate, it's just not ideal. You can't deposit enough heat in that area to cause true necrosis on really tall or large prostate. So not necessarily a great modality. But that said, for our patients who don't qualify or not good candidates for HIFU, I can offer them cryotherapy as well, and that's something that I can do transparency. I could go anterior, posterior. Tends to have a little more collateral damage, but oncologic efficacy is still great for cryo. So that's why I tend to use HIFU, which I think is a little bit more, safer on patients than cryotherapy might be. But the last thing that I think any focal therapy program really needs is a robust and strong radical prostatectomy program. And I think or radical, or radiation program. And the reason is because you have to be able to offer multiple modalities to have an unbiased view on which modality is best. So, for example, in my practice, I do a lot of prostatectomies. I do focal therapy. I don't have to have a bias in terms of which patients to push a certain therapy or not. I'm able to offer them everything and really talk to them about what the opportunities are, what the pros and cons are. It depends on the patient. Some patients don't like the risk of recurrence that may be a little bit higher for focal therapy, and some patients want maybe the prostate removed and they don't have to worry about it. So it's that conversation, that ability to offer multiple modalities is going to be really the important linchpin of any successful focal therapy program.
Yeah, I think that's a great point, right? We have being able to offer all these different modalities, surgery, radiation, focal therapy, it allows you to be open-minded and to treat the patient, and not just offer what you could offer, what you have.
And
And
David, just to add on to that, I think what we've seen over the last 10, 15 years, right? You look of a 30,000 foot view of this kind of whole space is we are offering more therapies. We're personalizing care, whether it be genetics or, artificial intelligence, whatever it might be. And we're able to better offer patients not just a one size fits all approach. And I think this is exactly part of that narrative. We're able to, I think, better characterize and diagnose patients with, advanced biomarkers. And now we're able to offer patients not just one or two treatment options, we're able to offer them more. And I think that's the whole point of kind of offering the patient what they really need, as long as we're able to talk through those discussion points with them.
right. And to that point, pretend I'm your patient for a second. All right. I have 3 plus 4, and someone refers me to you, and says, I basically asked them about focal therapy, and I come to you and I say, Doc, tell me more about focal therapy. How do you counsel patients?
Yeah, that's a great question. So I think how I initially start off saying is if you're intermediate favorable disease, I think what you're essentially asking me, right, for grade group 2 disease. I'd say, I think the options in this situation include surveillance, include radical prostatectomy, and they also include radiation, right? So kind of everything on the block. And I say those are the standard of care options, I think, in that scenario. What I also say is, there is an alternate option that is not quite standard of care, and that's focal therapy. And of course, I would have to make sure that that patient has exactly those criteria I talked about, right? Unilateral disease, hopefully MRI visible disease, not a large prostate. This disease must be kind of posterior. That way we can really deposit enough heat. And I'd say, this is not quite a standard of care at this point. It's not really in those guidelines, but, there's a lot of data out of Europe and Asia. And in America, we've been, kind of really starting to use this more and more in the last few years. And the difference here would be is, we're able to offer this treatment, but there may be, a 20% chance at 1 year that you continue to have clinically significant cancer in that area. But that said, the functional outcomes, I quote them about 5% risk of incontinence or erectile dysfunction. And I think in the literature, it's somewhere between 5 to 10%. But I think when you look at our data, that's really what it looks like. And I think we're able to say, the trade-off by having maybe a little bit more higher chance of having a recurrence or disease persistence is probably another word we can talk about. You may be able to benefit by having a better functional outcome here. So I had talked to them that this is kind of an in-between area, but we're able to offer this. And as long as they understand the risks of not only the recurrence or disease persistence at 1 year, I think patients are at least very interested to hear about what the next step is.